Today we're going to discuss maternity review. Here are some terms that you're going to see often and hear often whenever you are looking and working in labor and delivery, antepartum, postpartum. And so I would suggest you utilize your book. If you don't recognize these terms, look them up. If you have questions, you can definitely email me and I will help you discern some of these. So antenatal assessment, there's 3 critical assessments. We have to do a pelvic assessment. Then we have to do a uterine assessment and a fetal assessment. The pelvic assessment is going to help us determine whether or not a woman can deliver vaginally. This used to be something we did often, but now we kind of give everyone a trial of labor to see if they're able to dilate and descend. There were specific measurements that would be performed by the physician, and they would say, oh, you have an inadequate pelvis and you're going to have a C-section. And now we know that sometimes just by feeling, we can't necessarily 100% say whether or not someone is going to be able to deliver vaginally. So we usually will give them an opportunity to labor. And then, of course, if they don't progress, then that's when you would go on with a C-section. So we have Nagel's rule. So you take the first day of the menstrual period and you subtract 3 months and add 7 days. And this is usually going to give you your exact due date. The uterine assessment, we're going to do fundal height measurements, and this is McDonald's method. Using this, you're going to measure from the pubic symphysis to the top of the fundus, which is the very top of the uterus, and it's measured in centimeters. So if you measure 16 centimeters, you're usually around 16 weeks. Same with 20 centimeters, you're going to be 20 weeks. Sometimes if you do see a variation of larger, then you're thinking, okay, do I have someone who's further along, or do I have a baby who's large for gestational age or macrosomic? Or if maybe you're measuring smaller by 2 weeks, do we have a baby that has intrauterine growth restriction? The fetus, so we're going to start measuring the fetal heart rate. Usually you can hear the fetal heart rate with a Doppler at 10 to 12 weeks. The normal fetal heart rate is 110 to 160. Your vital signs are also very important in pregnancy. We're going to look at the blood pressure. How often or how high is it? So usually if you have a rise of 30 millimeters systolic and 15 millimeters diastolic, or over 140/90, then you could have preeclampsia. This is after 20 weeks, okay? So if it's before 20 weeks, then it can be considered to be pregnancy-induced hypertension, okay? Here is a picture of a woman's abdomen being measured from the top of the pubic symphysis there to the top of the fundus. So what are some danger signs in pregnancy? Do they have a sudden gush of fluid? Are they having abdominal pain? Are they running a fever greater than 101? Is there any dizziness, blurred vision, double vision, seeing spots, persistent vomiting, severe headaches, edema of the hands, face, legs, and feet? Are they having any kind of muscular irritability, convulsions? Are they having epigastric pain, difficulty peeing, lots of peeing? Are they not feeling the baby move? These are all danger signs. So your antenatal labs, your hemoglobin in a woman who is pregnant should be 12 to 16. If it's less than 11, then usually that can indicate anemia. We're also going to look at their ABO and their RH factor. If a mom is RH negative and the baby is RH positive, then this could cause some problems for the mother, which means over time they could become sensitized, meaning she's developed antibodies against that fetus. So in the first pregnancy, you're usually not going to have any issues. It would be the second, third, fourth on, okay? So what would happen is if the woman does not receive RhoGAM is kind of like a cloaking device. So it covers up any positive blood that may have crossed into mom's bloodstream from baby from the placenta. And so if that happens, then this RhoGAM kind of covers it up and doesn't allow mom's body to see it. And so this helps the mom to not produce those antibodies just because we want to reduce that risk of the body fighting against that positive blood type baby. So if a mom is sensitized, the antibodies break down, they hemolyze, so break down the fetal RBCs, and it can cause a miscarriage. It can also cause anemia in the infant or jaundice. So we're going to give that RhoGAM. The indirect Coombs is going to test to see if mom has become sensitized, but also test for any other types of antibodies. So we want to see a negative test. A direct Coombs is done on the fetus, and it's to determine antibodies covering RBC. So we're looking to see are those antibodies there, and we also want that to be negative. So hematocrit in a pregnant woman is going to be 38 to 47%. So remember, these women are considered hemodiluted. So they're going to have excess blood volume, not excess RBCs or anything else. It's just a blood volume increases. And so you're going to see a lower hemoglobin, a lower hematocrit. Your normal RBCs are 4.2 to 5.6. Your white blood cells are 5,000 to 12,000. We also are going to do a syphilis titer, which is also VDLR, STS, complement fixation test. You want this to be negative or non-reactive. Sometimes you'll also see it just say serology, which is the STS. We're going to do gonorrhea cultures, usually chlamydia cultures also. Glucose, you're going to see a little bit of glucose in the urine. So you want to make sure that if there is a significant amount of glucose, then they could be diabetic. So the normal blood glucose in a woman is going to be 70 to 120. The hepatitis B antigen, we want it to be non-reactive or negative. If it is positive, then we know that mom could potentially have hepatitis B, and that baby is going to need a second shot, not just a vaccine to prevent hepatitis B, but actual antibodies to help that baby to start fight against that hepatitis B it will be exposed to with delivery. HIV, of course, you want to be negative. So rubella titer 1 in 10 indicates that you have immunity, okay? If it's less than that, there is something called equivocal, which is kind of where you're borderline. Most physicians will say if it's equivocal, then you need to go ahead and be immunized again. A woman cannot be immunized for rubella, the MMR type in vaccination in pregnancy because it is a live virus. They can only be immunized post-delivery. Sickle cell is usually checked on patients with African descent. Of course, you want that to be negative. You want the pap smear to be negative. And of course, some physicians don't drug screen every patient. If we have a patient who comes in that's not using one of our providers or has no medical physician history with either one of our providers, we're going to go ahead and do a drug screen. So labor and delivery care. So when you have a mom who comes in to be admitted, we're going to look at the prenatal record. Hopefully it's been sent over from the physician's office. If it's a Dr. Knutsen's patient, you're going to have a paper chart that's going to come and will be in the drawer, and the nurse will pull it out and put it in the actual paper chart. If it's a Dr. Flores patient, you'll be able to access all the prenatal records within the Meditech system. So we're going to get a history on admission, okay? So this is on page 471 in your book. So we have the GTPAL, okay? So we have gravida. This is the total number of pregnancies, okay? How many pregnancies, including this one? Term, so how many term deliveries? Term is 30, like basically 38 weeks on, 37 to 38 still considered preterm. Preterm is how many preterms, so before 38 weeks. How many miscarriages? So abortions is elective abortions or even miscarriages, okay? And that's less than 20 weeks. Live births, that's the L. How many live births have they had? So the gravida para, gravida is how many pregnancies, including the current, and para is how many deliveries after 20 weeks. So sometimes, so I am a gravida 5, para 4, okay? But if you break mine down more, so I'm a gravida 5, term 4, para, okay, or preterm 0, abortion 1, living 3. And my gravida para is still G4. So I've had G5, P4. So I've had 5 pregnancies, 4 vaginal deliveries post 20 weeks. One of those was a stillbirth at 39 weeks. So I have 3 living children. So what are some signs and symptoms that we can see of labor? Okay, we can see lightning, which is the fetus settles into the pelvic cavity, so that allows mom to breathe. Okay, you would think lightning means lifting. No, lightning means that that baby has dropped down, that mom has a little bit more comfort, can breathe deeper, and usually feels a little less tight up top. Also having a dropped appearance. This is whenever that baby has come down and is lower than what they have seen in the past. Contractions. So you have 2 types of contractions. You've got real contractions and you've got false contractions. False contractions are called Braxton Hicks. They do nothing except cause mama some discomfort. Cervical changes, we're going to see, is it ripening? So is it softening? Is it dilating? So cervix usually is long and thick and closed, okay, before dilation occurs. And so we look at dilation, so how many centimeters open it is. And then we look at how effaced, so how thick that cervix is, and it's kind of backwards. So when we say 100% effaced, that means that cervix is super paper thin, okay? If it's thick, you're going to hear people say thick, that means it's long, okay? And then we're also going to be talking about how high is that baby up here in a minute. Ripen or bloody show can also be a sign. When a woman loses her mucus plug, usually it's within a certain time frame of delivery, but not always. I have had moms who've lost their mucus plug 2 months before delivery, 1 month before delivery. It's more so if they start to see more bleeding. Okay, they have the mucus plug come out, they'll have pink to even some bright red bleeding that's very minimal. Okay, that can be a sign. Of course, if the water breaks, then even if they're not in labor, that means they're going to have a baby. You can't go very long without having a baby. If they go past 18 hours, most of the time the physician's going to start an antibiotic to reduce the risk of any kind of infection to mom or baby. Sudden burst of energy. Sometimes you'll have a mom who will have a sudden burst of energy at 24 to 48 hours right before they go into labor. So this can also be called nesting. You'll hear people say nesting a lot of times. They're getting ready, they just feel really good all of a sudden, and then usually within a few hours they kick into labor. So let's look at true labor versus false labor. So with true labor, you're going to see contractions that are regular, so in a pattern, okay, every 3 to 5 minutes. The intervals between contractions usually are starting to get shorter. So maybe they start and they're having them every 10 to 15, and then they go 7 to 10 minutes, and then now they're 5 to 7 minutes, and then 3 to 7 minutes. So you're going to see them get closer and closer. The contractions increase in duration and intensity, so that means they're lasting longer and they're getting stronger. A lot of times they'll have back radiation that kind of comes around to the front. The intensity of the contraction will increase with walking. Cervical dilation and effacement is going to progress, so you're going to have cervical changes. And usually the contractions don't go away with rest or a warm tub bath. So false labor, you're going to have contractions that are irregular, and you may notice kind of that they're coming somewhat in a pattern or feel like they're coming, but they're still not as regular as what a true labor process is. The intervals between contractions usually do not change. They still maintain pretty irregular. The duration and intensity of the contraction usually doesn't change. They're usually pretty short, 30 to 50 seconds. They might seem a little stronger over some time, but most of the time they stay about the same. A lot of times women feel more of the discomfort with these in their tummy and their abdomen instead of in their back. Walking can cause the frequency to increase, but will decrease with rest, okay? But you will see sometimes, in your book it even says, that walking usually will make them go away. But in all my years of experience, I have seen that women will be up moving and they'll aggravate the uterus, because think, it's the largest muscle in your body at that time. When you're up walking and you're not well hydrated, what's going to happen? That muscle is going to contract. That muscle is going to get irritated and you're going to have contractions. And so usually once they go sit down and rest, they go away. You're not going to see any cervical change, and usually with rest and a warm tub bath, they do go away. So let's talk about labor. We've got 4 P's in labor. Okay, we've got our psyche or personality of our mom. This is our mom. Okay, what is her emotional status? Who's her support system? Okay. What value and beliefs do they have? What mental and physical preparation have they done for this childbirth? You've got the power, so this contractions and the pushing effort. What are the physiological forces of labor? It's that contraction itself. How often are you having them? How strong are they? How long are they lasting? And then how well is mom pushing when it comes time to deliver baby? Then we have passageway. This is our pelvis, cervical dilation and effacement. So is that pelvis opening going to be adequate to allow that baby's head through with the way it's positioned? Are we dilating? Are we effacing? Is that baby coming down into the pelvis? Is it going to fit? Then we have passenger, which is our fetus and placenta. So a lot of times people forget after that baby comes out, we have to deliver a placenta. So how big is that baby? What position are they in? So are they OP or OA? You're going to hear those terms. Are they looking down at the ground, which is OP? So the occipital, which is that, OA, sorry, let me get this right. Occipital anterior. So occipital is the back of their head, okay? And anterior means that it's at the top, okay? We want them looking with their face down to the floor. OP is occipital posterior. So that molding part of their head is actually facing mom's back, and their face is facing the sky when they're coming out. So that means that that part that's supposed to mold is not getting molded, and you're delivering pretty much the broadest part of the head first, okay? So what are our stages of labor? Okay, so we have stage 1. This is usually 0 to 10 centimeters, okay? And we have 3 phases within that stage. We have the latent or early phase, and this is usually 0 centimeters to 3 centimeters. You're going to have contractions anywhere between 3 to 30 minutes apart, 20 to 40 seconds in length. They're going to be shorter, usually less frequent. Active labor is 4 to 7 centimeters, and you're going to contract every 2 to 5 minutes, 40 to 60 seconds in length. And then you have your transition phase, which is 8 to 10 centimeters. Your contractions are going to be way closer together, about every minute and a half to 2 minutes, lasting 60 to 90 seconds in length. Stage 2 is 10 centimeters to delivery of the infant. So this is where we're pushing and having a baby. Stage 3 is the placenta delivery. So this is delivery of the infant to delivery of the placenta. So babies come out, and now we're delivering the placenta. And usually this should not last more than 20 to 30 minutes, okay? At 20 minutes, that doctor is going to start saying, okay, what do we need to do to get this placenta out? And I have seen moms who've had to go back and have a D&C completed to help remove that placenta. Stage 4 is very important. This is that first 4 hours post-delivery, okay? You're going to see the heaviest bleeding in the first 1 to 2 hours, and then from then it should get lighter, but it's very critical that you're assessing your mom often, and frequently to make sure she is not bleeding too much. So we have our fetal presentation, and there's several different ways babies can come down. You have your vertex, which is head down, their chin is flexed to their chest, and they're coming correctly. Breech presentation is footling or complete. So complete is when the buttocks is coming first, and there's also frank breech, which is with their legs up by their feet up by their ears. Complete is when they're kind of in that fetal position, but the butt's coming first. Footling is where you have a foot coming out first. You're going to see that most often in your preterms. Brow or face presentation, shoulder presentation. So you've got engagement. So the largest diameter of the presenting part reaches or passes the pelvic inlet. Okay, so that's when that head has come through that opening and you can feel it coming down. Not engaged, you're going to hear nurses say volatile or floating. So when you go to feel, you can feel that head, and sometimes you can feel it, but if you push up, that baby's going to float right away, and usually that's when you've got a mom who still has her water intact. Station, this is the relationship between the presenting part and the imaginary line between the ischial spines of the maternal pelvis. So think about the maternal pelvis at the front where you have this ischial spines. So it's something that you have to just think, okay, when I'm feeling this baby's head compared to mom's pelvis, where do I think it is? So if it's at that spine, it's 0. If it's above, you have to think, is it 1 centimeter above, 2 centimeter above, 3 above? So if it's above that, it's -1, -2, -3. Then if it's at that ischial spine, it's 0. And then as it moves down into that vaginal canal, you're going to say, how far forward is it? Is it 1 centimeter forward, 2 centimeters forward, or 3 centimeters? So fetal monitoring, we're going to see how is baby doing. Okay, so we're going to do 2 types of monitors potentially. External fetal monitor, which is a TOCO, and an ultrasound transducer. Your TOCO is what measures your contractions and goes at the top of the tummy at the fundus. And your ultrasound transducer goes over the baby's back. Internal fetal monitors, you have a scalp electrode and also an intrauterine pressure catheter. So the scalp electrode is actually a little electrode that screws into the top of the baby's head and allows you to monitor the heart rate more effectively. So if you have a baby you're having a hard time keeping on the monitor and you're needing to measure their heart rate due to induction, or maybe baby's having a lot of decels, it's going to be the most accurate for you. The intrauterine pressure catheter is the only way you can actually see how strong a contraction is, and it's just a air-filled catheter. We used to use water-filled ones, now they're air-filled, that goes up into the uterus between the uterine wall and the baby. And it just actually measures the actual pressure with every contraction. So that's the only way you can tell how strong. The TOCO that goes on the outside for contractions can tell us how often someone's contracting and how long the contractions are, but it cannot tell us how strong. The only way we can measure strength is by palpating and feeling mom's abdomen. So the normal fetal heart rate is 110 to 160. So how do we determine where baby's back is? We use something called Leopold's maneuvers. So you can see in the picture here, so A is you're feeling from the top of the fundus down. Where do I feel that baby's back? Okay. B, continuing our way down. C, do I feel the head down at the bottom of mom's abdomen at that top of that pelvic bone? And then D, can I feel then from the head along the side to where baby's back is? This is going to give me a better idea of where to put that monitor, but then also kind of give me an idea of how baby's positioned. So with the fetal heart rate, you can have fetal tachycardia. Fetal tachycardia is anything above 160. Fetal bradycardia is anything below 110. A cells on a baby who is 36 weeks or greater should be 15 beats by 15 seconds. So when you look at your fetal monitor paper, you have blocks. So when you're looking from left to right, that's the seconds. And then when you're looking from top or bottom to top, that's the beats per minute. Okay. D cells, you have several different types. So an early D cell will mirror your contraction. A late D cell will start after the contraction and end after the contraction. Your variable has to be at least 15 beats by 15 seconds in your dip, and you're going to see it more V-shaped or U-shaped, and it's usually going to be less than 2 minutes long. So here in a minute, we're going to talk about veal chop. So this example here gives us an idea of what our fetal baseline is. It's a little harder to see just because of it's the print, but you can see each block. So you can see your 120, and one block up is 130, one block up is 140, one block up is 150. So our fetal heart rate is running between the 140 and 150 line. So if we can draw a straight line through about where that baby's heart rate consistently stays, we can say this fetal heart rate is at 145. So here are some variations in D cells, okay? So an A cell, again, has to be 15 beats long. Okay, so here this one's 20 beats, the first one that you see there, and then it is greater than 15 seconds. It's 15 beats high by 15 seconds long. On your variable D cell column, you can see that you have a U-shaped D cell, and usually you're going to see kind of an acceleration in the heart rate right before or after or both. And it does vary, so the onset can vary. Doesn't necessarily mean that it has to be with the contraction, before or after. It's a variable. A true late or early D cell, you're going to see that long D cell, okay? So this one is a late D cell in your third column. We have our peak of our contraction and the lowest point in our dip, or our nadir of our D cell, do not match. So you can see the arrow that is drawn from the top of the contraction up. Your D cell is starting with the peak of that contraction. So that is considered a late D cell. So here's veal chop. So we have veal, and you're going to do your VEAL and your CHOP. So variables, which can be bad, usually it means cord compression. So our first thought is what's going on with the cord, but you're going to see some variables, okay? It can be non-reassuring if they are frequent and pretty regular. If they're random and just rare, then usually it's not anything too bad, okay? Early, which is okay, this can be reassuring. It just lets us know that baby's head is being compressed. That baby's head is coming down. It lets us know baby is moving. We usually like to see a few earlies. A cells are okay. A-okay is how I like to remember this one. Our oxygen is adequate. Our baby is doing okay. Late is bad, okay? A late D cell is non-reassuring. So it is telling us that our placenta and our uterus are not working well together. Is our placenta old? Are we having an abruption where that placenta is pulling away from the wall of the uterus? We don't know. So we need to make sure that we reposition, and we're going to talk about that. So when we have a late D cell, we have the big five that we need to do to help reduce the risk of problems and hopefully fix this baby, okay? So first, you're going to turn the patient, and preferably we're going to turn that patient onto their left side. This is going to allow the blood flow through those major vessels in the back to be more adequate. We're going to apply oxygen. Studies doesn't show that this really does much for the baby, but it makes the nurse feel better, okay? So we're going to apply that oxygen. We can't, every time that baby has a D cell, we can at least keep mom at 100% saturation, so when it can recover, it's got 100% O2 going into mom. So you're going to do a face mask at 10 liters, okay? Not a nasal cannula, usually a face mask with a non-rebreather at 10 liters. Turn down your pit or turn it off. I say just turn it off. If we've got some late D cells, especially if you're having to be in there and doing some significant interventions, we're going to turn it off for a little bit. Sometimes if it's just one or two that you've seen and baby seems to have a really good heart rate, the variability is good, you're not necessarily always going to turn it off immediately. But if you're in there because it's pretty significant, turn that Pitocin off. Then you're going to start an IV bolus. You're going to put that pump at 999 and make sure that you're hydrating your mom, okay? And then you're going to call the physician. Now, I had a student last year who posed this to me because when she was doing some of her UWorld questions, it did say first to notify the physician. If two people walk in that room, one will go notify the physician and the other will start the intervention. If you are the only one walking in that room, you need to start your interventions and then notify the physician. Because hopefully with your interventions, you're going to be able to allow that baby to recover and the heart rate get back to normal. With variable decels, you're pretty much doing the same thing, okay? We've got to reestablish some blood flow. The biggest thing with a variable is if it's around the time that mom says, hey, I think my water broke, or the doctor's in there and had just broke the water, and then all of a sudden you see this big variable decel, we need to check and make sure that there's not a cord, okay? So we must establish blood flow. So we need to do a vaginal check for cord prolapse, okay? So we're going to get that call light close by, and you may even, while you're doing the exam, have the patient push the button. That way you can talk to the nurse as soon as they come on. Turn the patient if you're unable to palpate a cord or relieve cord compression manually. So if you don't really feel any cord there, just have her turn to her side to see if it can get baby off, because maybe baby's just rolled over and lying on the cord. You're going to put some oxygen on, decrease or turn off your Pitocin, start an IV bolus, and notify your physician. So this is a really neat video. So it's just a really good animation to kind of show you how that cervix can change and how that baby comes out appropriately. That is the way baby should come out. They don't always come out that way. So now it's time to have a baby. So what are we going to do? So we're going to assist with vaginal delivery of the infant, okay? So there are going to be times as a nurse, as you're pushing that, you're going to get close, you're going to call for your physician, they're going to be out in the hallway or at the desk right there, but guess what? They got up to go to the bathroom real fast, and guess what? That baby's head's coming out. So let's think about the steps the physician is going to do and some things you may have to do also as a nurse, okay? So how do we assist with a vaginal delivery? So first we hope that head is coming out. That's our plan and expectation. So once the head is delivered, assist woman to pant or blow, okay? We don't really want them to push yet because that doctor is going to actually have to feel for a cord, or if you're the nurse and getting to deliver the baby, you're going to palpate for a cord to see if that cord is around the neck, okay? And you're also going to continue to kind of support that lower perineum to hopefully reduce that risk of tearing too much. You'll suction the nose or suction the mouth first, then the nose to clear out any secretions to reduce the chance of aspiration. On the next contraction, you're going to have the woman push, and as they push, those shoulders will deliver, and usually you're going to kind of pull down and you'll see the doctor pull down, or you'll pull down to have that first top shoulder deliver and then the bottom shoulder deliver. And usually after the shoulders come out, the body just comes right with it. So the umbilical cord. So a baby's cord is its lifeline when it's in utero. So when do we clamp the cord? Okay. So usually the cord is clamped after it's no longer pulsating. Most physicians do this. It's not anything that is done by every physician, but most will let it pulsate, and once it kind of slows or stops, they're going to clamp the cord. Okay. You usually want to hold that baby below the vaginal canal so that it can get whatever blood is left from the placenta and the cord back to mom. And you're even going to see some physicians will, what they call milk the cord, will actually milk it down towards baby. How to clamp and cut the cord. We are going to use 2 Kellys, or you'll notice the physician goes ahead and does 1 clamp, the actual plastic clamp, and then a Kelly or a hemostat. And then they're going to cut between the 2 or have the father or significant other cut. So who examines the cord? The cord. You do. That's your job as the nurse. You're going to look and see. So what are we looking for? We should have 2 arteries and 1 vein, because in the umbilical cord it works a little backwards from our body. So the vein actually delivers oxygenated blood to baby, and the arteries take unoxygenated blood from baby back to the placenta to then be oxygenized from mom's blood. So it's a little bit backwards. So think AVA, artery, vein, artery, okay? So right after the baby is born, you're going to maintain respirations, okay? So we're going to think about ABCT, airway, breathing, circulation, and thermoregulation. You're going to put the baby on its back, on mom, or even on its side, or if baby's having some difficulty, you may have to take it to the warmer. You're going to keep that baby warm, so we're going to dry the newborn, remove anything that's wet, and get skin-to-skin contact with mom as soon as possible. If baby has to go over to the warmer, we're going to leave the baby uncovered. We're going to put a skin probe on so we can monitor temperature. And set that from manual to baby's temperature on the warmer itself. We're going to also cover that baby's head with a cap to help reduce the risk of heat loss. We're going to go over the APGAR score. It is done at 1 minute, 5 minutes, and 10 minutes, okay? You want to make sure that you're looking at the heart rate, the respiratory effort, muscle tone, reflex, irritability, and the color. There is a video that I have posted for your simulation that is going to go through this in detail. So when we're assessing baby, we're looking at all these things here, okay? There is a newborn initial assessment. There's a video on your simulation link, so on your modules, so you can watch that to look and see what we're assessing. Here is the Ballard score. The Dubowitz is also a part of the Ballards, and so you can actually see how you look at their posture, you look at their wrist, arm recoil, how can they angle their legs, how do they hold their arms, how far over can you push their arms. So if they're more flexible, they're younger, okay? So how do we identify these newborn babies? But mothers and newborns are going to get matching bracelets in the room before the baby ever leaves the room. There are times that sometimes we do have to rush baby to the newborn nursery, but you're going to have a nurse that's going to follow right behind with those bracelets and ID baby and mom as soon as possible, okay? They're going to have a security device that goes on their umbilical cord. We're also going to do footprints, and we're going to make sure that we have a footprint sheet that has the number that matches mom and baby's bracelets. You're going to always check that baby's ID band with mom's band. You're going to check the ID band against the chart each shift. You're going to tell the parents that most of our employees that work on the floor are going to have a blue badge versus the black badge. Sometimes, though, we do have people that float up, but I usually try to, if I'm the day shift nurse giving a report to them as night shift, I just let them know that she is there helping. That's why her badge is not blue. Keep the infant away from the doors. We have a security code on the nursery door, so not just anybody can walk in. If the mom leaves the room for any reason and doesn't have someone who can stay with baby that has a baby bracelet identifier, then that baby needs to come to the nurse's desk with a nurse or go to the nursery with a nurse. We always document when the baby leaves the nursery and is returned back to mom, and know what to do when the alarm is sounded. So if you hear the alarm go off, like say there's a baby box that got left in a blanket that a mom was discharged, got put in the laundry, and so the people are trying to take it down to launder it. Well, it's going to make the alarm sound in the elevator, and you're going to hear the whole system go off. So it's the job of the staff on that floor, even over on the medical side, to go to the doors, the exits, and wait. And then the rest of the staff then goes and searches in every room to see if the babies that are supposed to be there are there, and they still have their identification intact. If they don't, then of course, that's where the missing baby is from. Most of the time, it's just related to someone has left the box in the laundry or it accidentally got thrown away. Okay? So bonding time, we have the golden hour that we do at Southwest Med. So we want to do skin to skin. You usually want to try to not do the erythromycin until mom and dad have held the baby and the baby has looked at them, because it does cause it to be a little bit blurry. You want to kind of dim the lights, and of course we do rooming in. So vitamin K is what we use to help prevent bleeding, okay? That liver is immature, it does not make any clotting factors, that their tummy doesn't have the normal flora yet to help make vitamin K. So we're going to give them vitamin K to help reduce the risk of bleeding. So we give 0.5 to 1 milligram within 1 hour of birth. It's IM. You're going to do vastus lateralis or rectus femoris, and we usually always do vastus lateralis. We're going to use a small, short needle, 25 gauge, about 5/8. So we do eye prophylaxis with erythromycin. This is to prevent the neonatorium ophthalmia from the gonorrhea. It also can help reduce the risk of eye infections from other bacteria. So we're going to usually give erythromycin ophthalmic ointment. Sometimes you'll see, I've actually never seen anybody use silver nitrate. I've only ever really seen people use the erythromycin. You're going to hold the baby's eyes open and kind of just squeeze a strip over that baby's eye. Do not put the tip in the baby's eye. You're just going to hold it above and let it drop down. Glucose monitoring. So why might we do glucose levels on a newborn? So if we have a diabetic mom, have a baby that's too big, too small, are they having signs of low blood sugar? So what are those? Lethargy, jitteriness, hypotonia, so their muscles are real loose. They are having seizures or tremors, okay? They could be poor feeders, poor sucking, they're vomiting, they have a low temperature. They might have like that grayish color, pallor tone. They could have respiratory symptoms, high-pitched cry. Their Moro reflex can be very exaggerated. So what is a normal glucose level for a newborn? It is 40. Okay, anything 40 or above, usually they say 100, is acceptable. So we've already talked about some of the signs of hypoglycemia. Just went through those. So what are causes of hypoglycemia? Infants of diabetic moms, prematurity, small for gestational age, asphyxia, there we go, cold stress, epidural anesthesia for mom during labor. So you're going to give that first feeding usually within that first hour if they're breastfeeding. Okay, we want to get them to breast as soon as possible. Formula feeding is usually done later. It's in that second period of reactivity, usually within that 2 to 4 hour window is when we're going to go ahead and start feeding. If we have hypoglycemia, we definitely are going to feed as soon as possible. Okay. So safety, again, we have ID bands, security bands. Who can hold the baby? Only staff or those with identifying bracelets. And we're never going to leave a baby alone in the room, and always have hands on baby if the baby is not in the crib. Circumcisions, the decision with our patients is usually kind of cultural. Not every culture sees circumcision as a need. We definitely need to make sure they're well educated about if they do want to do it, and if they don't want to do it, cleaning under the foreskin if they're not getting circumcised. That's part of our job to educate. So what is the nurse's role? We need to get informed consent from the parents. We're going to check for any history of bleeding disorders with the parents. We're going to get all of our supplies together. We're going to put the baby on the restraint board, assess for signs of too much bleeding, assess for the first void after the circumcision, because if there's too much swelling, they're not going to be able to pee. We're going to teach the mom and dad how to do the circumcision care. So postpartum care. So vital signs. Blood pressure should return to pre-labor normals. The pulse sometimes can be a little lower the first hour or two. You want to make sure that fundus is right in the middle, about 1 to 2 fingers below the umbilicus, sometimes right at the umbilicus, and that's okay. That lochia is going to be bright red and usually heavy like a period. Sometimes you're even going to have some pads. So that first 2 hours is pretty significant bleeding, okay? You're going to see about a 4 to a half a pad covered in 15 minutes, okay? But that's why we're doing fundal rubs every 15 minutes, is assess that uterine consistency. Is it firm versus soft? We're going to look at the bladder. Is it palpable? Is the uterus high and to the right? That means that bladder can be full. What does the perineum look like? It should be smooth and pink without a bruising or edema, but you will see edema often. What is their emotional state? Okay, they could be excited, happy, sad. Okay, so our bubble heat is breasts. We're going to assess their breasts. The uterus. Is it firm or boggy? Okay, is it high and to the right? Are we doing our fundal rubs every 15 minutes? Bladder, when was the last time they voided? Bowel, when was their last bowel movement? Do they need a stool softener? L, lochia, so how much? How much is too much? More than 1 pad every hour after that initial 4-hour period is too much, okay? What is the color? Rubra, serosa, alba. So rubra is that bright red, serosa is kind of that in between, and alba is the white. Episiotomy. So did they have a tear or an episiotomy? We need to be assessing that. What does the swelling look like? Is it well approximated, or is those sutures bulging due to swelling? Are they having any pain? Is there a hematoma? That is why it's very important to assess if they've had a tear or a episiotomy, because you want to make sure there is not a hematoma, because that can cause other complications. What are their Homan signs? So what are we looking for with Homan signs? Okay, so pregnant women and postpartum women are at increased risk for DVT. So we're looking to see if there's that DVT. So we're going to take that foot, push it towards the patient. If they feel any pain in that calf on one side or the other, then we need to assess them further for a possible DVT. Emotions. How is mom bonding? Does she have postpartum blues? Are there early signs of postpartum depression? If she has a history of clinical depression, does not necessarily mean she will have postpartum depression, but she needs to be assessed. So there we have it. There's our postpartum, our labor, postpartum, and newborn information. Of course, there's videos listed also on your module. Watch those videos to help you prepare for clinicals on Thursday and Friday.